Hello and good evening. Thank you again for joining us and welcome to this series of webinars, updates on glycemic control biomarkers in diabetes. Today is our second lecture. The first lecture was given by the Professor Dr. Pierres on the current state of diabetes management. Today, I had the great pleasure to have Dr. Elizabeth Selvin, who is a professor of epidemiology at the Johns Hopkins Bloomberg School of Public Health. And she also holds a joint appointment in the School of Medicine at the Division of General Internal Medicine, where she serves as the co-director of the Cardiovascular Disease Epidemiology Training Program for the Bloomberg School of Public Health. Dr. Selvin will be discussing today the glycemic control markers and going beyond hemoglobin A1c to guide diabetes therapy. It is a great pleasure for me to have Liz, as we cordially call her. Thank you so much for accepting to be our faculty, and let's just begin today. Welcome in.
Hi, everyone. I'm Liz Selvin. I'm a diabetes epidemiologist and a professor at the Johns Hopkins Bloomberg School of Public Health. I'm very excited to talk to you today about glycemic control markers and going beyond hemoglobin A1c to guide diabetes therapy. So I'm going to discuss today various non-traditional biomarkers of hyperglycemia. So I'm going to compare and contrast traditional and non-traditional biomarkers and discuss their strengths and limitations, describe their prognostic utility, and discuss their potential clinical value in diabetes care. There is growing interest in the use of alternative or non-traditional markers of hyperglycemia. These alternative markers may be complementary to hemoglobin A1c, and they may also be potentially useful in settings where hemoglobin A1c is problematic. There's been statements from diabetes and laboratory organizations where they've suggested that these biomarkers may be useful, but their long-term prognostic value is unclear. So I'm going to focus today on some of the evidence for the long-term prognostic value of these alternative biomarkers of hyperglycemia. So first, sort of to compare and contrast the different biomarkers that we're going to be talking about. The traditional measures of hyperglycemia that we're used to seeing are glucose, or typically fasting glucose, and then also hemoglobin A1c. And hemoglobin A1c is an indirect measure of chronic hyperglycemia, typically reflecting glucose exposure over the prior 2 to 3 months, where, as we know, glucose is an immediate or acute measure of glucose at that moment in time. Fructosamine is a measure of total glycated serum proteins, which, as you know, are mostly albumin. Glycated albumin is expressed as a percentage and is the proportion of albumin specifically that has glucose bound to it. So the focus of today's talk will be on fructosamine and glycated albumin. But I also wanted to mention 1,5-anhydroglucitol, or 1,5-AG. 1,5-anhydroglucitol is quite different. So 1,5-AG is a monosaccharide. It originates from the diet and is normally stable in serum. But when glucose is high, so that is when glucose exceeds the renal threshold, 1,5-anhydroglucitol is excreted in the urine and serum levels drop. So low serum levels of 1,5-anhydroglucitol reflect periods of hyperglycemia or glycosuria. So our standard measures of hyperglycemia have some limitations, and that's particularly relevant for today's talk. So glucose, for example, only tells us about glycemic status at that moment in time. And of course, fasting is needed if we're talking about fasting glucose. And it's very common for patients in practice to be non-fasting. And so that's a major limitation of fasting glucose. Glucose has high within-person variation. Glucose measured after a carbohydrate challenge, or 2-hour glucose, is a very sensitive test, but also has very high subject burden and has even higher variability as compared to fasting glucose. So both of these glucose measures have very high within-person variability. Hemoglobin A1c overcomes some of these limitations as it's a measure of chronic hyperglycemia. It's relatively unaffected by acute factors. It's a non-fasting test. It's worth noting that hemoglobin A1c is more expensive than glucose, and for that reason is not as widely used globally. And then there are conditions that can alter red cell turnover. Those will also alter or affect hemoglobin A1c. So hemoglobin variants can interfere with some methods, although most modern hemoglobin A1c assays are robust to common hemoglobin variant interference. One thing that's I think often not properly recognized about glucose is that there's a substantial amount of pre-analytic issues or sample stability. So improper collection, or if the samples aren't immediately put on ice or collected in the proper fashion, that can result in interference in glucose measurements, and typically resulting in glucose values that are too low. And of course, because it's an acute measure, anything that occurring that morning of the glucose measurement can acutely alter levels. So before I spend the rest of the talk about alternatives to hemoglobin A1c, I think it's important to mention the strengths of hemoglobin A1c. So hemoglobin A1c, as we said, has much less biologic variability, especially as compared to fasting or 2-hour glucose. It's this integrated average of glucose exposure. So it's this index of chronic hyperglycemia, which makes it a very useful test. And it's, I think I've seen recent statements by experts actually criticizing hemoglobin A1c because it doesn't reflect hypoglycemia and doesn't change rapidly. But the fact is that because hemoglobin A1c doesn't change rapidly in response to external factors such as diet and physical activity, that's actually what makes hemoglobin A1c so useful. So one of the greatest strengths of hemoglobin A1c is that it is a stable measure of chronic glucose exposure over a 2 to 3 month time window. So it's an extremely important and reliable measure of chronic hyperglycemia. Some other advantages are that we have very strict standardization for the hemoglobin A1c assays, thanks to the National Glycohemoglobin Standardization Program, or the NGSP. And it's a very familiar test. It is the standard measure that's used to guide and adjust treatment in diabetes care. So let's discuss the current use of these different biomarkers of hyperglycemia. So glucose measures are widely used for screening and diagnosis of diabetes. Hemoglobin A1c, also now widely used for screening and diagnosis, and as I mentioned, is the gold standard test that we use for monitoring glucose control in the setting of diabetes. Fructosamine is available for clinical use. It's not commonly used. It's sometimes used when hemoglobin A1c testing is known to be problematic. Glycated albumin was recently FDA cleared for clinical use in the United States. It's widely used in Japan and some other countries for monitoring short-term control in people with diabetes. 1,5-anhydroglucitol, which I'm not going to focus on today, but I do want to mention is available for clinical use in the United States and is available in most of the major reference labs. It's not widely used. It is reimbursed by Medicare and Medicaid and some private insurers. Its clinical utility is really less clear than these other alternative biomarkers. So as I mentioned, we're going to focus today on fructosamine and glycated albumin. So why might we want to use these tests? So the reasons to use fructosamine and glycated albumin is that they may add value to our standard measures. So going beyond hemoglobin A1c and fasting glucose, that fructosamine and glycated albumin may enhance risk stratification, and they may be also useful for monitoring short-term glycemic control. They may be particularly useful in populations where hemoglobin A1c is problematic. So any situation where red cell turnover is altered. So if in certain anemias or in the setting of hemoglobin variants or where there's been recent blood loss, or in situations where hemoglobin A1c is not available, where there wasn't, for example, a stored whole blood sample to measure hemoglobin A1c. So fructosamine and glycated albumin may have utility in settings where short-term, where 2 to 4 week glycemic control is of particular interest. So if we want to know shorter term changes in response to treatments, and then also short-term glycemic control is often of particular interest in short-term clinical trials, and particularly resource-intensive trials such as feeding studies. So, I think there's growing interest and there's growing use of these biomarkers, which really suggests that we need rigorous studies to help inform their clinical use. This is a statement from the American Diabetes Association, where the American Diabetes Association said simultaneous measurements of fructosamine and the hemoglobin A1c test might complement one another and provide more useful clinical information than the hemoglobin A1c test alone. However, additional studies are needed to confirm the clinical utility of this approach. And so that's really the question, is whether fructosamine and glycated albumin can add complementary information and be used in a complementary manner to hemoglobin A1c to help enhance diabetes care. So what are some barriers to the use of fructosamine and glycated albumin? So its clinical utility is much less well characterized, especially compared to hemoglobin A1c. The associations with fasting glucose and hemoglobin A1c itself are less well characterized. The prognostic value has only been shown to date in a few studies. And so consequently, the complementary nature to hemoglobin A1c is less well characterized for these biomarkers. Other reasons and other sort of barriers to use include just a lack of familiarity of healthcare professionals with these assays, and also a lack of formal guidance from major medical organizations regarding their use. So we've published a series of studies to help establish the prognostic value of fructosamine and glycated albumin. And we've also done a number of studies examining 1,5-N-hydroglucitol. I'm going to talk today about some of our results, specifically for fructosamine and glycated albumin. So these studies were all conducted within the atherosclerosis risk in communities cohort, or the ARIC study. The ARIC study is a large community-based cohort of over 15,000 Black and white adults who've now been followed for more than 30 years. I feel very fortunate to be part of the ARIC study. I've been an ARIC investigator for many years now, and this has been an incredibly important study in terms of looking at the risk factors and the natural history of diabetes and prediabetes. So for the particular studies that I'm going to talk about today, we measured hemoglobin A1c, fructosamine, and glycated albumin in stored blood samples collected at the second ARIC examination, which took place in 1990 to 1992. And then we have subsequent follow-up for many different major clinical outcomes in all of these individuals. And there were about 14,000 individuals who attended the visit 2 examination. So our study objectives were to characterize the associations of fructosamine and glycated albumin with both microvascular and macrovascular outcomes, and compare these associations to those that we observed for hemoglobin A1c. So we conducted a series of prospective cohort analyses using Cox proportional hazards models, and we had over 20 years of follow-up at the time for both incident microvascular and macrovascular events. Our exposures were fructosamine and glycated albumin measured in serum samples, and we also measured hemoglobin A1c in stored whole blood. And we looked at the associations of these biomarkers with retinopathy, with incident chronic kidney disease, incident cardiovascular disease, and then also all-cause mortality. To give you some idea of the study population here, the mean age was 57 years. We have a slight majority female population. Just under a quarter of our study participants were Black adults. 11% had a history of diabetes. Almost 30% were obese, and 35% had hypertension. These are our baseline levels of fructosamine, of glycated albumin, hemoglobin A1c, and fasting glucose. And so as you can see, we have much higher values of all of these biomarkers in individuals with a history of diagnosed diabetes, as would be expected, as these are measures of hyperglycemia. I think it's worth noting that the mean hemoglobin A1c is 7.6% in people with diabetes, and the mean of a hemoglobin A1c of 5.4% in adults without a diagnosis of diabetes really reflects that this is a community-based general population of adults. So these are scatter plots for fructosamine here on the left, and glycated albumin on the right. We have hemoglobin A1c across the top and fasting glucose across the bottom. And so what you see is overall high agreement of fructosamine. Oh, sorry about that. So overall, you see very high agreement. So for both fructosamine and glycated albumin with hemoglobin A1c in these top graphs, and also very high agreement of fructosamine and glycated albumin with fasting glucose. So we're seeing overall Pearson's correlations of over 0.8 across these different plots. So very high agreement amongst these different measures of hyperglycemia. I also wanted to show you the scatter plot for fructosamine and glycated albumin. It's worth noting that fructosamine and glycated albumin are even more strongly correlated with each other. So we have an overall Pearson's correlation here of 0.93. So these two biomarkers are very strongly related. So some of our initial results here. So this is a traditional approach to looking at hemoglobin A1c and fasting glucose with prevalent retinopathy. I've added fructosamine and glycated albumin here. So this just shows you the deciles of each of these biomarkers and then the prevalence of retinopathy within each decile of these different biomarkers. And so what you see here is that at lower levels of each of these biomarkers, at the lower deciles, we do not see much prevalent retinopathy. There's just not a lot of retinopathy in the population. But at high levels of each of these biomarkers, for example, in the 10th decile here, we see a substantial prevalence of retinopathy. And we see that the pattern observed is similar for each of these 4 different biomarkers. So to put the biomarkers on even footing for the next analyses that I'm going to show you, we used equivalent percentiles pegged to clinical cut points of hemoglobin A1c. So clinical cut points of 5.7 and 6.5% in people without diabetes, and then clinical cut points of 7 and 9% in people with a diagnosis of diabetes. So we have, these are the percentiles for hemoglobin A1c, and then we looked at cut points for fructosamine and glycated albumin at the equivalent percentiles. So we're looking at the 75th percentile, the 70 to 95th percentile, and the greater than 95th percentile in people without diabetes, and then less than the 33rd percentile, the 33rd to 67th, and then greater than this 67th percentile in people with diagnosed diabetes for each of these different biomarkers. So these are the adjusted odds ratios for the association of hemoglobin A1c, fructosamine, and glycated albumin with retinopathy. So what you see here is that hemoglobin A1c and fructosamine and glycated albumin were similarly associated with the prevalence of retinopathy in persons both with and without diabetes. So we see extremely strong associations among people with a history of diabetes. And these results are very consistent with the figure I showed you previously with the data binned according to deciles. So these are the adjusted hazard ratios for the association of these biomarkers with incident chronic kidney disease. So we see similar but more modest associations with risk of chronic kidney disease. So, and again, the associations for hemoglobin A1c with incident chronic kidney disease, fructosamine, and glycated albumin are similar. So across these 3 different biomarkers, we're seeing very similar associations with the future risk of chronic kidney disease in this general population. And this graph just shows the same results, but here the hazard ratios are modeled graphically continuously using splines. So we can show you the association across the full range of both fructosamine, glycated albumin, and hemoglobin A1c. And again, what we see is similar associations, similar patterns of risk across the different biomarkers in terms of the hazard ratio for incident chronic kidney disease. Although it's worth noting that the association with hemoglobin A1c does appear to be somewhat more linear as compared to the fructosamine and glycated albumin association. So lots of data here. These are hazard ratios, again, modeling fructosamine, glycated albumin, and hemoglobin A1c using splines, and looking at our cardiovascular outcomes. So we're looking at the associations with coronary heart disease, with stroke, with heart failure, and with all-cause mortality. And again, looking in this ERIC study population, we generally see similar patterns for the associations of these 3 different biomarkers with these cardiovascular outcomes and all-cause mortality. I wanted to just mention a separate study. So this is a dialysis cohort. So this is not the ERIC study. This is a separate study we published in Diabetes Care, where we examined the association of fructosamine and glycated albumin in a dialysis cohort. And we also showed a robust association with mortality in this population of US hemodialysis patients. So some key conclusions from these studies are that fructosamine and glycated albumin are strongly correlated with hemoglobin A1c and fasting glucose. We also found that fructosamine and glycated albumin were associated with prevalent retinopathy, with incident chronic kidney disease, incident cardiovascular outcomes, and all-cause mortality. And we found that the associations of fructosamine and glycated albumin were similar in magnitude to those associations we observed for hemoglobin A1c. So some implications of this research includes that accepting new biomarkers of hyperglycemia really depends partly on establishing their associations with outcomes. So hopefully these studies really go a part of the way in terms of helping establish their prognostic value. Our results suggest that fructosamine and glycated albumin may be reasonable alternatives to hemoglobin A1c, and they may be complementary to hemoglobin A1c for monitoring shorter-term glycemic control or when glucose or hemoglobin A1c results are problematic. It's worth noting that the data in ERIC are from a community-based population, so other studies in specific populations, such as pregnancy or anemia or HIV, are still needed to really establish the prognostic value of these biomarkers in other specific population subgroups. I think the evidence for the value of glycated albumin and fructosamine to help improve diabetes care is strong. A major barrier to the use of these biomarkers is a lack of guidance in clinical guidelines. We have clear evidence that these biomarkers can be measured reliably and are valid, and we now have a lot of evidence and growing research to suggest that they may be useful complements to hemoglobin A1c. So hopefully our work and the work of others can help inform practice and result in formal changes to guidelines. So I have many people to acknowledge. I have many collaborators and wonderful colleagues at Johns Hopkins and other institutions. All of the work that I presented today was funded by the National Institutes of Health. I would especially like to thank the staff and participants of the ERIC study, without whom none of this research would be possible. And I want to thank you all for listening.